So I have the pleasure of introducing Dr. le Roux. So Dr. le Roux graduated from medical school in Pretoria, South Africa, completed his senior house officer training at St. Bartholomew's Hospital, his specialist registrar training in metabolic medicine at the Hammersmith Hospitals, and his PhD at Imperial College London. He was appointed as a senior lecturer and later promoted to reader at Imperial. He started his role as Chair of Pathology at University College Dublin in 2012, where he now works within the Diabetes Complications Research Centre. He previously received a President of Ireland Young Researcher Award, Clinician Scientist Award from the National Institute Health Research in the UK, a Wellcome Trust Clinical Research Fellowship, and an Anglo American Open Scholarship. Dr. le Roux is recognized for his work in the role of appetite and metabolism in obesity and diabetes. However, I would say that the latter sentence represents a major understatement. Dr. le Roux is internationally recognized as a top scientist, speaker, and thought leader in the role of appetite and metabolism in obesity and diabetes, and more specifically within the context of bariatric surgery. Dr. le Roux's work has been instrumental in advancing our knowledge and understanding of mechanisms underlying weight loss and diabetes remission and resolution after bariatric surgery. Indeed, he is one of the individuals that is most responsible for facilitating studies of mechanisms beyond restriction and malabsorption. And with that, I give you Dr. le Roux.
Do you want to? Yeah, we're just going to hit that. That's fine. Hit start. There you go. That's it. Well, thank you very much for this great opportunity to talk at this important meeting. And I sort of termed this talk, we thought we knew why patients ate less after surgery, but do we? And I often start with this Renoir to remind us that obesity is not necessarily an ugly thing, but what I want to do in my clinical practice is take patients such as these with increased visceral adiposity and who suffer from diseases and actually help them to turn into patients such as those in the background with a better quality of life and who are disease-free. But to do that, we need to understand why these patients are hungry, and when they eat, why don't they feel full? Because if we can't fundamentally change those two things, we will not be able to help them in the long term. Those are my conflicts of interest, and I also show a Roux-en-Y gastric bypass there, because most of my work has focused on the gastric bypass, but of course we're doing quite a lot of work with sleeve gastrectomies and gastric banding, and actually learning that all of these operations have real value, although they may work in very different ways. When we need to start by saying, how do these operations work, we need to understand that it's the only way where we can actually get people to lose weight, but more importantly, to help them maintain the weight loss. In my practice, I can make anybody lose weight. I lock them in a room for 2 months, I give them 2 liters of milk and a multivitamin every day, and when they come out after 2 months, they would have lost a quarter of their weight. But they would be incredibly hungry. And at that point, they would regain all the weight that they have lost. So what we need to understand about surgery is not how it makes you lose weight, but more importantly, is how it's actually able to maintain the weight loss for several decades. Now, we now understand that there's multiple factors and that surgery doesn't have one silver bullet. And that's also going to make it very hard to actually because there's not going to be one hormone or one neuronal signal. It's going to be this plethora of multiple signals that's working at the same time. But that also probably explains to us why surgery is so effective for so many individuals. Because, of course, obesity is not a single disease. It is it's a cause of multiple different etiologies. Now, of course, by using a treatment such as bariatric surgery that have multiple factors, we can actually help so many of our patients. But maybe it's just surgery works because people are really motivated, they have an operation, and then you and I in our multidisciplinary clinics suddenly break through to the patients, and for the first time, they listen to what we've been saying to them for decades in the past. Or an alternative hypothesis is that actually surgery works through changing biology. So what we have done in our research setting is actually see what happens to rodents who've never met a multidisciplinary team. They've never been assessed, they've never had all the teaching that we can actually give our patients, but we can actually do these operations on the rodents, and when we actually do bypasses on these rodents, they lose a third of their body weight in comparison to those animals that have a sham operation. But more importantly, when we take the plasma from these rats and we inject it into healthy recipients that have not had any surgery, the recipients of the bypass plasma eat a third less than the recipients of the sham bypass, suggesting to us that whatever is making the animals eat less food may be carried in plasma. So focusing more in on our rodents, and again, as I say, the benefit is because they haven't met any of us in the multidisciplinary team, so they are unencumbered by social pressure. But what we can actually do is we can actually offer them different types of food. We can offer them high-fat food, or we can offer them low-fat food, or even high-fat food that are masked with this thing called Bisto, which is a sauce that we have in the United Kingdom, sort of a contribution to world cuisine, if you wish. But what we can actually do in offering these to the rodents, we can measure their direct behavior. We can measure what food they eat. And when we actually do this, and this is work done also by Huta and Ashrafian that's in the audience today, we can actually see that before they have the surgery, they will eat mostly high-fat food and high-fat food with Bisto, and they'll eat very small amounts of the low-fat food. However, after the operations, those animals that had sham operation eat the same amount and the same percentages of food. What is striking, however, is those rats that had a bypass eat significantly less food, not dissimilar to our patients. They still eat high-fat food and high-fat food with Bisto, but surprisingly, they have a 4-fold increase in the amount of low-fat food that the rats are eating. Now, you try and make a rat eat low-fat food in preference to high-fat food, suggesting to us that there may be something physiologically happening. Now, let's go to our patients. And the problem when we actually speak to our patients is so many of them have suffered with discrimination for so many years, and so many of them have seen multidisciplinary teams where we have tried our best to actually help them, but sometimes got a bit frustrated and, have actually put pressure on the patients and not really understood their situation. So very often, if we ask a patient, how much do you eat, or, do you eat breakfast, or what type of food you eat, they look at us and they think to themselves, what does this individual want to hear? And I will just tell them what they want to hear, because if I really tell them, then they'll just think, I have a lack of moral fiber. I'm not trying hard enough, or I'm not smart enough, or I'm not motivated enough. But if we actually ask people the same type of questions before and after surgery, we may sometimes get some insights, but it is we should always take it with a little pinch of salt. So what we've done here is we've asked patients before surgery, after we've given them a 400-calorie meal, we said to them, how hungry do they feel right now? And you can see those are the responses of before they have surgery, and of course they start feeling hungry very quickly. But after surgery at 1, 3, and 6 months, hunger remains suppressed. On the opposite side, if we ask them how full do they feel right now, you can see after a 400-calorie meal before surgery, they don't feel much satiety, but afterwards at 1, 3, and 6 months, the satiety of fullness is elevated and remains so. Now, again, you ask the patients, you spend so much time with the patients, probably more than any other member of the multidisciplinary team. And I remember an old boss that I had that always told me the truth is in the patient. Just ask them and they will tell you. And you hear the stories and you hear also the variation. But very often, we do hear that people say, you know what, now when I eat food, I can eat the same food as the rest of the family. But when they eat off a dinner plate, I eat off a side plate. and that actually allows me to feel satisfied. And of course, if you eat fewer calories, it's unsurprising that you can actually lose weight. But why do people eat less food? Yes, I told you when we look in plasma, there may be signals, and I'm very important to say it is not the only signal. And I'm going to show you some of the hormonal responses, but by no stretch of the imagination is there one hormone that explains it all, or you should go away thinking that we can do all of this by just changing hormones. But it is still an important signal because it tells us that there is biology that is important, and not only psychology. So what we can see here is that people that are overweight or obese have a very small amount of response after they have a 400-calorie meal. But after an operation such as a gastric bypass or sleeve gastrectomy, these hormonal responses are elevated significantly. When we look prospectively, what happens to these hormonal responses, this is before surgery at 1, 3, 6, 12, and 24 months. And you can see how the hormonal responses go up and remain elevated as time goes on. However, in your practice and my practice, there's some patients that have exactly the same operation that before surgery behaved exactly the same, but after surgery, some of them lose 40% of their weight and some of them only lose 20% of their weight. And when we actually now look at the hormonal responses in those patients, it appears that those that actually have the best weight loss also are associated with the best hormonal responses. And those that actually have the poorer weight loss are associated with poorer hormonal responses. But that's only association. So if I want to try and convince you of causation, what I now need to do is suppress those hormonal responses and then see what happens. So that's what we've done here by giving Octreotide, which is a somatostatin analog, and it effectively blocks all the hormones. And when we do this with gastric banding, there's no changes that happens. But after a gastric bypass, if we block the hormones, you can see that there is a significant elevation in the amount of food that people eat. So by just blocking the hormones that the gut naturally produces after a gastric bypass, we can make people eat more food. We haven't changed the pouch size, we haven't changed the limb length. All we've done is taken the hormones away. But take note that although we've blocked all the gut hormones, if patients are given an ad libitum meal, yes, they double their food intake from about 400 calories to about 750 calories, but they don't go back to eat 2,000 or 3,000 calories as they may have done before surgery. So the hormones again explains some of the effect, but not all of it. But what happens just down the corridor from your clinic? Most of us are now so focused on bariatric surgery that we may not engage with our other surgical specialities or our other colleagues down the road. So what happens to your colleagues who are actually looking after the upper gut cancer patients? And so here's patients who have had oesophageal cancer. And of course, they would have an Ivor-Lewis type procedure that looks anatomically not completely different to a sleeve gastrectomy. And what you would see in patients who've had esophageal cancer and then go on to have surgery and then go into remission is they lose weight and they maintain their weight loss exactly the same as many of our bariatric surgery patients would. The difference in these patients are that they don't want to lose weight, because if they actually have lost weight, it is a sign of that they are unwell, and they actually would like to gain weight because they don't want to have the stigma of cancer in this setting. So why are these patients losing weight and not able to regain the weight that they have lost? Exactly the same as our bariatric surgery patients, we can see there is an elevation in the gut hormone levels after the oesophagectomy. Now, what happens if we actually block these gut hormones? And what you can see over here is by blocking the gut hormones with Octreotide, we can again, exactly the same as with the gastric bypass patients, we increase the amount of food that they consume in an ad libitum meal. Now, of course, not many of our bariatric surgery patients would like to gain weight or would come to you and say, please, can I gain weight? Can you give me an injection for that? but actually this may be a therapeutic insight for those patients who have lost weight with cancer. And I would like to say to you that yes, it's very important that we actually communicate within the multidisciplinary team and learn, not from each other, but we shouldn't become so isolated that we actually forget to learn from our colleagues next door who's actually looking at other parts of medicine, because otherwise we actually develop next to each other, but we don't learn from each other. So actually talking to each other will actually give us a lot of insight as time goes on. So I'm going to summarize this part of the talk and say if people are lean, the more food that they consume, the higher the satiety levels will be. However, if you're obese, you need more food to actually reach that same level of satiety. And again, I will challenge you, go back on Monday to your clinics and ask your patients the two different questions. The first question is, do you feel hungry? And they will say, no, I'm not sure actually I feel that hungry. I can easily skip breakfast. I don't feel hungry for breakfast anymore. And then second question is, what happens if you start eating? And most of your patients will say to you, as they do to me, the problem is when I start eating, I don't feel full. I need vast amounts of food before I reach satiety. So again, we have used terminology like appetite that doesn't actually help us distinguish between hunger and fullness. So again, one of the messages from this talk is, I think we need to get our nomenclature and our terminology clear so that A, we know what happens when we talk to each other, but also what happens when we actually talk to our patients. And I would suggest to you that most of our patients with obesity don't feel hungry, but their real problem is when they start eating, they don't feel full. So therefore, our treatments need to be focused on that. But what happens after an operation such as a gastric bypass or sleeve gastrectomy, that is shifted to the left, and therefore fewer calories will allow people to actually reach satiety. Now, this is work that comes out of Gothenburg with Anna Lorenius and Torsten Olbers's work. And what they carefully did is monitored patients from the preoperative state, and you can see how the patients lost weight and maintained their weight loss between 1 and 2 years. But when we actually measure the amount of food that they've eaten, then something comes to the fore that you hear all the time. So patients actually do really well in the first year, they actually lose the weight, and then between 1 and 2 years, most of them actually maintain their weight loss. But you and I get those telephone calls when the patient says, doctor, or it's actually the operation's not working anymore. I can actually start eating again, and I can eat a vast amount of food. And I have done so many diets in the past, and I know this is going to fail because so many times, this is exactly what happens. But when you go back and you weigh them and measure their body mass index, you can see that actually they've lost weight and they've maintained the weight loss. But when we directly measure how much food they eat, you are correct, and the patient is always usually right, that yes, they've eaten much less food in the first 6 weeks, but then at 1 year and 2 years, they're right up there, and they're actually eating a large amount of food. But if we just weigh that food. But typically what happens if the wife comes with a husband who've had surgery, then the wife would say to you, doctor, I'm not sure what you did with my husband because this is the type of food that he ate before the surgery, and now when we go to a restaurant, he goes to a salad bar. This guy has never eaten a carrot in his life before, and now he's asking me to prepare vegetables for him at home. And again, Houghton Asrafian coined the term, I don't